Hey, good morning, everyone, and welcome to EuroNurse. I'm your host, Vic Senese. Glad to have you on board. If you're watching us live, great, fantastic. Be sure to use the comment box to go and put any questions that you might have during the show, and be sure to subscribe and like our show. If this is your first time checking us out, be sure to go to our website where you can learn more about the show. A couple of interesting areas that up on the top where it says Ask EuroNurse. If you're unable to use the comment box or you have a question that you didn't think about or you're watching it on demand, you can always use that to send questions. We do get those and post them during the show sometimes. Also, if you're interested, you could always look into more information if you want to be a host on the show. Best place to go to catch all of our past episodes. We're up to 86 of those episodes now. Hey, want to hear us in your car? No problem. Go ahead and check in our audio podcast by going to our EuroNurse Plus area. That's the area to check us out, and any of your favorite podcasting ways, formats are available. Also, we have if you're a patient and you're watching this show, great. But we really have an area for you called the EuroPatient Podcast at europatient.com. These are episodes that are specifically aimed at patient education. Follows this show at 10:30, so you can check us out. This week, we're going to talk about iTin, so be sure to check us out. Also, we have a great area of handouts for helpful handouts after every show. Whatever we've discussed, I've got a handout that you can download and take home or keep home to bring to your next visit. If you're not getting our e-news, then what are you waiting for? Go to our website, sign up. It's super easy. We use MailChimp, so your email is never revealed to anyone else, and we don't sell your email to anyone, so it's perfectly safe. This week, I'm going to be talking about a subject near and dear to my heart because it's the very first episode that I ever gave. It was on PSA. So we're going to look back at that episode and then do an update, and I'll be glad to talk more about that because I'm the presenter. Hey, let's go ahead and bring in our experts to the show. John's joining us today. Welcome to the show. Hey, John, go ahead. I'll let you go ahead and do your introduction since I'll be taking over for the show.
All right. Good morning. I just want to say good morning to Nancy, Susie, April, Diane, who are joining us live this morning. I'm passionate about helping urology practices succeed so they can reach maximum clinical and financial success. To that end, I created the Thriving Urology Practice Facebook group where we crowdsource practice management solutions for everyone's benefit. I frequently speak on the topics of coding, billing, revenue cycle management, marketing, and how to run your practices more efficiently in the era of declining reimbursement and rising practice overhead. I'll be speaking at the Rocky Mountain Urological Society in April, the AUA annual meeting in May, Texas Urological Society meeting in June, Louisiana Urological Society meeting in August, South Central session of the AUA meeting in October, and finally, Urology Advanced Coding and Reimbursement Seminar in December. So if you're attending any one of those meetings, please come by and say hello. I'm John Lynn, a private practice urologist in Gilbert, Arizona, and I look forward to our discussion today. Back to you, Vic.
You know, it's a shame, John, that you can't find more stuff to do. But you know, that's a word. Once you kind of get involved in this, it's easy to move on. People start to recognize you, become like mini celebrities, I guess, you know.
Well, the thing is, I try to do things differently. You know, as an immigrant, I came to the States and I didn't come with much of anything. So we qualify for subsidized lunches, which back in the day, if you want to, I'll just talk to you about this real quick. Back in the day, I had to go I was actually called up to the front of the classroom during our homeroom period by our homeroom teachers. And she called my name, so I had to physically go up to the front of the classroom to get a lunch ticket. So I felt a lot of shame when I had to do that. Ever since then, I think I have a chip on my shoulder. I always have to do things better than somebody else, including public speaking. So last year, I took a virtual masterclass on public speaking. I really put in a lot of effort to try to do this better. When I give presentations, it's not just somebody standing on the stage behind the podium. I don't do it like everyone else. So when you stand out in a good way, I think people take notice and they know that I put in a lot of effort in my presentations and not just, I don't do it like everyone else.
Yeah. That's a good point. I think that sometimes you watch the show and you think, wow, these guys just, they're really good at winging it. We're not good at winging it. This is all practiced.
This
It's
is
what it
so
takes.
much practice.
And even this weekly episode gives us every time you learn something new. Every time you put in an episode, you come up with new ideas, and it's really great.
And
So
I like what you do because you are constantly iterating the minor tweaks on your shows. Having done a lot of the same live production that you do,
mhm.
I know how much work it takes. So I really appreciate you putting on the effort and energy.
All right. Well, let's go ahead and get into our show. I'm the host, Vic Senese, and I'm also going to be your speaker. Been involved in urology for the past 40 years, created UroNurse just for this reason, to educate people. And that's where we're going to go right now. So let's see. I need to click that. There we go. So let's go and get in a time machine and go back to that very first episode, which was back August 5th, 2022. We're going to go ahead and check that one out right now for you. So today I'm going to talk to you about PSA and prostate biopsy, chicken or the egg. And I think I'll make it apparent why I call it that. So as we know with PSA, it's found in all normal prostate cells. And I used a box here as my example because the prostate cancer, if you look under a microscope as a biopsy sample, they kind of look like boxes. And we know that normal cells have PSA, prostate cancer cells have PSA. So PSA comes from all these places. The nice thing is it's found in the blood, so it's simple enough to just do a quick test where we just draw some blood. And we've come up with what we consider our normal range. So anything that was greater than 4 was considered too much PSA. So we know that the cells are not perfect in holding PSA. So they do leak a certain amount into the blood. And so what we have here is a patient with normal prostate cells and cancer cells. They all contain PSA. And one of the theories is that with cancer, it causes destruction of the cells. And again, look under a microscope at a cancer, prostate cancer, and you'll kind of see that the cells are nice boxes where it's not cancer and these kind of blown out looking things where it isn't. So it kind of makes sense that, the PSA would stand a better chance of leaking out of those boxes, and we would see a higher concentration of PSA. And that's exactly why we see that. Now, with any test, we always want to kind of weigh the difference between how sensitive it is and how specific it is. So, for example, digital rectal exam, sensitivity. Well, until there's a nodule, really you don't feel anything, so you're detecting prostate cancer when it's gotten to be pretty advanced. Specific, it could be a stone, it could be a prostate cancer, or it could even be a little cyst or something. So it's not a very sensitive, not a very specific test, but it was the best we had. That was our screening. So again, we look at those two measures. Now, when we look at PSA, what we have is a unique ability to be very sensitive. Some would argue too sensitive at picking up prostate cancer at the cellular level before it starts to spread and become a hard enough nodule. What we don't have is a very specific, meaning that when PSA is elevated, it's not just because of cancer. But in 1994, the FDA did give the nod because of the sensitivity to use PSA as part of a screening routine for men with prostates. I guess all men have prostates. So for our prostate group. So anybody 50 years or older should have a PSA and a digital rectal exam as of 1994. And they kind of ignored the fact that the specificness of the test wasn't there. I'm avoiding saying that word because I keep stumbling over specificity. BPH, prostate, UTIs, digital rectal exams, ejaculation, exposure to Agent Orange. We have a lot of Vietnam vets who have hit that prostate age. All can cause the PSA to go up. And one of the other things is sensitivity can be adjusted based on age. Now, it's not a real thing that we adjust. It's an artificial adjustment. And basically what we've done is said that, hey, probably somebody who's very young, we need to catch their cancer because they're the ones that are going to die of prostate cancer. And somebody who's very old, maybe we shouldn't be catching all these cancers because they're going to probably die with prostate cancer. So you can adjust the numbers. So the sensitivities, as you can see from my chart here, for a young man under 50 is up to 2.5 for an older man, 70 and older, up to, excuse me, 6.5. So it's an artificial adjustment, but it does make sense that you don't want to detect too many cancers. And it probably makes sense, the chicken and the egg. So we have PSA coming along, and that's going to drive biopsies. And that's exactly what it did. Once we started using it as a screening exam, the numbers of biopsies went up tremendously. Of course, the chicken and the egg, if you do more biopsies, you're probably going to detect more prostate cancer. And that's exactly what happened. So much so that in 2008, a group of many of the medical groups started getting together and saying, wait a second, this is a little bit too much. We may be doing more damage than good. And the thought was detecting prostate cancer early may not reduce your chance of dying from prostate cancer. That's important. It's always nice to diagnose cancer, but these very low-grade tumors that tend to act more like benign tissue are being diagnosed along with aggressive tumors like, your Gleason 7s, but they shouldn't all be treated the same. And it'd be nice if we could not detect those very small tumors. Plus, a number of PSAs have, negative results. So what we really needed to do was to find a way to increase the the specificness of the PSA test. Otherwise, it's just like flipping a coin, the accuracy just based on PSA alone. So one of the first things that came along is a test called free versus total PSA. And we know that some of the PSA is not bound to other proteins. So you can measure that as it compares to total PSA. And we get this table. And basically, there's a couple caveats. Number one, it only works on PSAs between a level of 4 and 10. And the percentage would then indicate that if it was a very low percentage, that there's a very high probability of finding prostate cancer. Now, that's just finding all prostate cancers. Really, what I think the goal is to find high-grade prostate cancers. PSA density is another option that we look at. PSA density is often not performed ahead of biopsy. It's done usually during a biopsy. The PSA, you measure the volume of the prostate, but at least it gives us an indicator for a big prostate probably causes more PSA to be produced. It just makes sense. You've got more mass, it's going to leak out more PSA, and that would explain it. And if you divide the two and your number comes out to be less than 0.15, your risk of it being due to cancer is less. It's probably caused by large prostates. So we already do a biopsy anyway, and when the results come back and it's negative, the doc can feel pretty comfortable saying, hey, you probably just have a big prostate. That's why your PSA went up. Now, this is the one that I think is one of the most promising, and it's called iso-PSA. And at this point in my career, I kind of pick and choose what I like to do. And the prostate work is really my favorite. So I'm really involved in prostate biopsy. I'm involved in the procedures, Urolift and Resume that treat prostate enlargement. But with the prostate biopsy, this is a new one that just started popping up on our test. And I see two scores, the iso-PSA and the regular PSA. Iso-PSA is 80% accurate in predicting high-grade cancer. Now, that's important. That's what we want to go after. So for those that are wondering what iso-PSA is, so instead of looking at the concentration like PSA, how much, how concentrated it is in the blood, you can actually look at the structure of the PSA. And there's by adding a reagent, it breaks it into two iso components. And you can look at those just like, as you remember from your old chemistry set, oil and water, oil floats on water. So the same thing happens. And you can find the ratio of where this breakdown is and utilize that number to predict who should be receiving a biopsy and who probably doesn't need a biopsy. You have a iso-PSA less than 6, you have a 92% chance of not having a high-grade cancer. It's above 6. So what's happened now is when I see patients for prostate biopsy, I'm seeing a PSA of 10 and an iso-PSA of 7. The 6, 5, 4, 3s, they're not even showing up. And since it is highly accurate, it's reasonable. And as somebody who has to have a PSA every year, I can tell you that if my PSA was elevated, I'd want to know my ISO PSA. To complete it, 4K score is another test. It's using prostate-specific biomarkers. It uses 4, thus the 4K score. Total PSA, free PSA, intact PSA, and human kallikrein 2. Also looks at some other factors. Urinary biomarkers are another thing that we looked at. So there are some specific cancer-produced biomarkers that can be found in the urine. They do a test where they do a rectal exam to express prostate tissue into the urine. You urinate it out, and then they can come up with some numbers as the risk of whether you needed a prostate biopsy or not.
Did the audio go away?
You know what? Thanks a lot, John, for reminding me. I forgot to hit my audio button.
Okay, we're good.
All righty. So anyway, hopefully everybody enjoyed that look back into history. But remember, that's about 2 years ago, almost back in August. So now we're going to update it because there has been a lot of changes, and the risk of prostate cancer still remains pretty high for men. If you have a group of men in a room, 1 out of those 8 has prostate cancer. Doesn't mean that they're all diagnosed for that, but that's what the risk is. What's really become more apparent, and we knew about it for probably the past decade, is this thing called low-grade prostate cancer. And low-grade prostate cancer is those Gleason scores of 6. And the thing is, those have a very low rate of causing metastasis or cancer. Actually, they say only 3%. And that's whether it's treated or not, die of prostate cancer with truly low-grade prostate cancer. And that's why we see all this other stuff popping up now. Active surveillance early on wasn't even a thing. And then around 2014, about 26% of patients were going into active surveillance for low-risk prostate cancer. Now, 2021 statistics have over doubled that. And I'm sure 2024, it's even higher. But thousands of men with prostate cancer get risky treatments they don't really need. So we need to think of something to curb that. We know low-grade cancers such as GS6 or Gleason score 6 account for up to 70% of new diagnoses. Let that sink in a little bit. 1/4 to 1/3 of men with a PSA of 4 to 10 who have a biopsy will turn out to have cancer. But most of these are harmless. So I think we need to look at our thinking on PSA, because we put patients through all sorts of treatments because they have prostate cancer, radiation therapy, surgery, and those things don't come without their risk. There's a lot of side effects to these treatments. Yes, when needed, makes perfect sense, but take somebody who may have that 3% risk, and you're going to put them through a surgery or radiation. And I'll give you an example. I remember a patient of ours that had a radical prostatectomy. He was a roofer, pretty fit guy in his 60s, had the prostate biopsy or prostate removed, and ended up with a stress leak. Now, it wasn't a bad leak. It was just because of the type of work he did, he would leak when he was working. The rest of the time, he had good control. And it really drove this guy nuts because he was a young, fit 60-year-old and wanted to get back to work, and he did, but now he had to wear some kind of a pad to absorb that leak that would happen when he would bend over to pound shingles or whatever. And you imagine on a hot roof wearing a diaper, not a good thing. So these side effects can be huge if you're the patient. We always kid around and say that if it's a 3% risk, but you're that one of those 3%, that's 100% for you. The other thing we don't always think about is the psychological effect when you tell a patient they have cancer. I mean, for some patients, like, yeah, let's get in there, let's get it. What do we need to do to fix this? For other patients, it's devastating. It's their life has changed. Probably for most patients, their life has changed when they hear that C word, which is what really kind of spurred me to want to do this talk at this time, because I started reading a lot of these articles that have come through lately on this changing the whole name from prostate cancer to something else. This, again, is not all prostate cancer, low-grade prostate cancers, those G6s. And, if you look at, we all know that the Gleason score of 6 is actually a low score. Patients assume that it's in the middle because the Gleason scale being on a 1 to 10, but it's not. The lowest Gleason score is typically a 6, a 3 plus 3. So 6 is actually low grade. And that's why they started throwing out this thought of changing the name. And a couple of names I've seen go out is idle indolent lesion of epithelial origin, or inert indolent neoplasm rarely requiring treatment. So instead of telling a patient they have cancer, you tell them it's idle or it's inert. And we know this is a problem worldwide. There's an overdiagnosis of early prostate cancer leading to overtreatment, leading to the expense and everything that we just talked about. So we know that there's got to be a way to have some smarter screening availabilities, better ways to not screen the patients who shouldn't be screened, tailor our diagnosis and management. And the nomenclature part, I think that makes a lot of sense. And this would not be the first cancer to get a new name. We can see there's been all sorts of low-grade tumors that have had changes from their label of cancer, the cancer label, to something less threatening. So I think this makes a lot of sense. You can put in the comment what your thoughts are. I'm strongly in favor of it. So just a reminder of what Gleason scores are for those of you that are in the audience that may not be familiar. But that lowest grade 3 plus 3 is a group grade 1. We kind of group them into group grades of 1 through 5. And the ones are the ones we're looking to affect right now. So in 2023, the AUA and the SUO, which is the Society of Urologic Oncologists, got a group of experts together and said, maybe we need to write some guidelines to better control this issue. Now, I've done work with the AUA in the past and been involved in 2 or 3 white papers with them. And this is the guidelines they use for their evidence, to have evidence proof or evidence provided research. And it's ABC quality of evidence. So strong evidence. There's lots of supporting literature out there that you can point to. B and C have less and less. But also because we are bringing experts together, they can also quote on clinical principle, just, what everybody seems to agree on as a group of urologists who are specialists. And since these are experts, even their opinion. But with that qualifying that this is opinion, not an actual backed up by evidence. So with their recommendations, and by the way, this study is going to be on the UroNurse website next to the video. So if you're watching it on demand, you'll be able to go and download this information, that study. But the PSA screening, the first thing that I really like is they're talking about making this a shared decision-making process. Now, clinical principle, but most urologists agree that the patients ought to have a say in some of this. Now, it's grade A evidence when screening for prostate cancer. PSA should be the first screening. So there's strong evidence saying PSA is the best way to start. But for people with a newly elevated PSA, clinicians should repeat the PSA prior to secondary things like biomarkers, imaging, or biopsy. Expert opinion, there's not data out there, but that's what they felt. Clinicians may begin prostate cancer screening and offer baseline PSA tests to people between the ages of 45 and 50. Clinicians should offer prostate screening sooner to people with higher risk, such as Black ancestry, germline mutation, strong history of prostate cancer. It's pretty good evidence on that. Clinicians should offer regular prostate screenings every 2 to 4 years. That's a change. And there's strong evidence, grade A evidence, that we shouldn't be screening every year. I just read an article that's interesting on the yearly blood tests for, cholesterol and, the CMPs and the CBCs, that there's really very little good effect from doing those every year. And it's a kind of a waste of money. But I think everybody just kind of does some things just out of dogma. Clinicians should personalize the rescreening interval, deciding to discontinue screening based on patient preference, age, PSA, prostate cancer risk, life expectancy, and general health. Grade B evidence on that. Clinicians may use digital rectal exam alongside PSA to establish a risk of significantly clinical disease. Grade C. For people undergoing prostate cancer screening, clinicians should not use PSA velocity. How many out there have been using PSA velocity as a marker? There's no good evidence for it. It's not something that gives us good information. And we'll talk a little more about that. Clinicians and patients may use validated risk calculators. Be interested in the comments if anybody's using those. I'm going to demonstrate one of those in the talk. When the risk of clinically significant prostate cancer is sufficiently low based on available clinical, laboratory, and imaging data, clinicians and patients may forego near-term biopsies. So that's clinical principle, but we all know these patients who come in and you can look at them because of their they've got bony mets and all this other stuff, and we're delaying to wait for a biopsy. Not probably necessary. So I took some key points out of the study that I read from the AUA and SUO. PSA, elevated PSA. So repeat in patients with newly elevated PSA, it turns out that if you repeat it, it'll go back to normal level in 25 to 40% of patients upon retesting. And I think that was not done very much in the past. We're certainly doing more of it now. And I'll even throw in some of the articles that I was looking at say that second PSA should be with a free PSA. That's really starting to give us a lot of great information. It's been around for, it's quite a while, at least the past decade. This is another dogma thing a lot of you may have been doing. I don't know. We did in our practice. Antibiotics should not be utilized to treat elevated PSA in an asymptomatic person. So don't just assume that the PSA is elevated because of a underlying infection. Another dogma, digital rectal exam, bicycle riding can appreciably alter PSA. There's no evidence to really support that. We've had many patients say, I just had sex. Maybe that's what caused the PSA to go up, although that it does have an impact. It's not significant. And that original threshold of 4 is probably too high for young people and too low for old people. Moses didn't come down with a 4th tablet that said 4 is the magic number for PSA. So for people at an average risk of developing prostate cancer, there's no randomized evidence showing a benefit to the initiation of routine screening for prostate cancer before the age of 45. So pushing it earlier does not benefit. Black individuals have a disproportionate cancer burden to white folks, twofold higher risk of death. And some of that risk is because of lack of treatment in that area, that demographic. Patients with less than a 10-year life expectancy screening is not likely to provide any benefits. So if somebody's, got, I got an 80-year-old neighbor who's got pulmonary fibrosis. He does not have a 10-year lifespan. He certainly would not be somebody for needing prostate screening. Large-scale studies in Europe and the US have shown the addition of PSA velocity does not help. And actually, they show very high velocities are most closely associated with inflammation on the biopsy rather than cancer. So what that really brings us to is 4 to 10, those just slightly elevated PSA area. Those are the patients that we should be thinking about, not necessarily doing. It used to be kind of a knee-jerk reaction. We get a patient comes in, PSA is 4.5. Okay, set them up for a biopsy. That should not be the routine. And I was talking about this prostate risk trial calculator. If you've got a phone, you can click that, scan that QR code. It'll bring you to that. Otherwise, that's the web address for it. But I'm going to show you what that looks like. I thought it was kind of a cool thing. So basically what it takes is various characteristics and goes over those. And so you put these things in here. So you mark your race, your age, your PSA level. So here's a 66-year-old guy, I guess actually adjusting for PSA for age, that's probably still considered normal. No history of prostate cancer, normal digital rectal exam, never had a biopsy. We do know the percent free PSA is 26. And those other 2 biomarkers are options. If you have them, you could add those in. And then we get the screening, which shows, and I got to tell you, these little dots here that you see that are gray, they should be green, but I'm using a green screen. So it's basically blank, empty, so I can show behind it. But anyway, as you can see, so 4% chance that we're going to find a cancer that would actually be somebody who needed to be treated, 4%. And 13% are going to be low grade that we probably shouldn't be treating. The rest won't even have a biopsy. Now, remember, the one issue is, biopsies are not benign test. There's about a 2 to 4% risk of somebody ending up getting sepsis from that. And as I said earlier, if you're in that 2 to 4%, it becomes 100% for you. And if you've ever had sepsis, you probably know something you don't want to go through again. If you've treated it, it's kind of risky business. So you try to avoid that at all costs. So let's see what happens when we change a few of these parameters. So the big one I changed over here is the PSA. Same, everything else the same, but now we've got a PSA of 10. Whoa, high PSA, right? We put it in the risk calculator. Again, 6% chance of having needing a treatment type cancer. Again, we're putting through 85% of guys that probably don't have cancer through this test and putting them at risk. Another time we'll change a couple parameters. The PSA is slightly elevated at 5, but now this percent free PSA. So show how this really changes the whole talk. So now we're seeing that we're going to be, much greater risk of finding cancer in these patients and treat cancers that need to be treated. So now this is a discussion that you need to have with the patient. These are your risk, and you can use this calculator as some supporting evidence as to why you might want to biopsy this patient. And then this last one here is low PSA, but also a low free. Remember, free should be over 25%. So what happens when that happens is, again, it shows you the amount of that free PSA can play into this calculation. So we have, again, a higher risk of finding, more like 50-50 with the lower PSA, but still, over 50% risk of finding prostate cancer, and almost 20% of those that would probably be in need of treatment. So these are patients that you want to talk to about this. Now, once again, Moses didn't come down with a fourth tablet that said the PSA risk calculator is from the mouth of God. It's a good study. I think it's something that has a place, but all this takes clinical judgment. This is where the physicians really come in handy. So the other question now is, we've got these better ways of screening, but we're going to have patients that come through. Who needs a biopsy? Who should we be repeating our biopsy on? And there's this nice algorithm here that was also accompanies the study here. And I'm going to go through it because I think it's worth looking at. But so when patients come in for their original screening in this area here, we get them involved in it. We tell them what the risks are, and we take a look at the age of when we're going to start it. So again, as we mentioned, lower age for people at higher risk, 45 and higher for patients who are not at risk. We do the first PSA test, and then if that comes back normal, we just go back into screening. But instead of screening every year, we may want to resume that of a 2 to 4 year basis. Now, if it comes back elevated, repeat the PSA. Perfect sense, because some of those are going to come back down and may prevent biopsy. Some of those won't. When you do this one, make sure you get that percent free. Some of the typically the percent free was only done between 4 and 10. So that's where they felt it was the most use. I was listening to a talk show on this, and they were saying that even lower numbers, 3s and 2s, can have a free PSA and give some data. So I think that's going to probably change in the near future. But if it does prove to be a high risk and elevated, come back elevated again, then we go on to our next stage, which is, what do you do with an elevated PSA? Again, a risk assessment. Do we have those others before we go into a biopsy, which we would have just done as a knee-jerk reaction? We start looking at some of these other things that we can do. Prostate MRI, if we think that this might give us some value, probably will. If it's PIRAD show up, a PIRAD 3 or higher, then we go to biopsy, targeted biopsy, MRI. If it doesn't, and there's strong evidence that they're probably at a high risk for greater than Gleason 6 prostate biopsy, then we should initiate a prostate biopsy, go into that prostate biopsy. If they don't, then we may go back just to the whole process, starting back at 1 again, and just redoing AUA biopsy, screening. If they come back with a positive biopsy, then we need to, again, think about, or I'm sorry, not positive, one of these ASAPs, these kind of benign but highly suspicious. Do we rebiopsy them? We go into this for a negative biopsy. Patients with prior negative biopsy screening should not be based solely on the negative biopsy, on a negative prostate biopsy. So again, they can go back to this 2 to 4 year screening, or based on risk, personalize that to maybe checking it sooner. So risk assessment, things like the free PSA biomarkers, again, are followed. Elevated risk, we go on to adjuvant biomarkers, MRIs, kind of the same process that we were getting. Positive finding in any of these, we go on to repeat biopsy. Positive PIRAD, we go on to targeted biopsy with MRI. So I think it gives us a nice flow chart for how we should be treating and biopsying patients. Well worth considering, instead of that knee-jerk reaction just to go back into doing a biopsy. With that, I'm going to go ahead and bring in our experts here. And there we go. All right. Well, John, welcome to the show. And any comments, questions that you guys have, feel free to put those into the questions. John, I'm going to go ahead, since I did all the talking, let you do a little talking. What do you think? Have you been looking at some of these things? What's your decision-making process?
Yeah, I follow pretty much what the AUA recommends, the guidelines. Although the guidelines are just guidelines, you have to individualize each patient depending on the wishes of the patients. And I literally said to a patient this past week, sir, we don't do the paternalistic thing anymore where I tell you what to do. We have to come up with the plan together. But this was an older gentleman. He said, no, I just trust what you tell me. Yeah. So you can try the shared decision making, but that you do have some older folks and maybe some younger folks who want you to kind of say, this is what I would recommend. So you do the best that you can. The C word is definitely very scary. And it has, as you mentioned, it has psychological, physiologic, and financial impact. And that's why we're having this discussion today with this elevated PSA. And the dilemma is when the PSA is slightly elevated between 4 and 10, what do you do? And that you did a great job in discussing the nuances. Somebody in the comments, Nancy, said, as a nurse practitioner, I repeat PSA, especially in an avid cyclist. And she also said, I tell them to stop cycling for 3 to 4 weeks. And that's the dogma, I guess. Stop cycling, avoiding sexual activity. And I do that as well. I tell the patients when they initially come in with elevated PSA, so the question is, would it have made any difference if the patient abstained from sexual activity or avoided bicycle riding when he undergoes a repeat PSA testing? So if he had not abstained from sexual activity or cycling, and you simply repeated the PSA, would it have come down back to normal? That's always the question, right?
Right.
So studies have shown that the sexual activity, the recency of sexual activity makes no difference, and the recency of cycling makes no difference in PSA. Nevertheless, a guy coming in with elevated PSA, don't jump directly into a multiparametric MRI. Don't jump directly into a prostate biopsy. Repeating the PSA. I personally can do a rectal examination, and I tell the guy, because he's usually a little anxious, I tell the guy, this is the worst part of my job, except talking and dealing with insurance companies.
Absolutely.
So you try to make light of it and try to make it a little not so much about what he's about to go through. You try to bring the attention to you so that he can take his mind off of what is about to happen. And bony metastasis, you said not to biopsy when the patient has significant bony mets.
Well, I said don't delay treatment.
Oh, don't delay treatment.
Right. That you could go ahead and start treatment, especially with like things like Lupron, et cetera.
The thing is, insurance companies, well, I guess you can always just say prostate cancer in your EHR and make that diagnosis. Mm-hmm. On the other hand, you may want to consider a very limited biopsy. I had an instance where a gentleman, I diagnosed prostate cancer in this gentleman. He ended up passing away not necessarily from prostate cancer, but he had insurance. He had cancer insurance. So I never did a biopsy on this guy because his PSA was way, way high. He had Mets, but I didn't do a biopsy. So he was not eligible to make that claim of cancer for his cancer insurance after he passed.
Yeah.
So that's one reason to do maybe a limited biopsy so you can get that pathologic confirmation, or unless you want to talk to the patient, hey, do you have a cancer insurance? If so, maybe we should consider doing a biopsy so that you would satisfy the policy requirements for your insurance.
Yeah, I agree with that. And it was a clinical opinion, based on urologists saying, "Hey, do we really need to delay?" Based on somebody. I mean, we all know, we see these patients, they got cancer.
Oh yeah,
but I can
PSAs
tell
in
you,
the hundreds.
Yeah, our practice has always been, what we do is exactly what you just said, limited. We probably do like a 2+2 biopsy, just two samples on each
because
side.
you can't miss. You do a biopsy anywhere, you're going to find cancer.
Yeah, if you've ever, I'm involved in ultrasound all the time with these patients. I mean, you look at the prostate, you can't even recognize a prostate. The walls of it, or the architecture is just blown out. You look at the core that comes out of the needle, it just looks thick and yellowish, and you can tell the difference between it. I mean, but I agree with you. There's a perfect case where it's good to always have tissue diagnosis to kind of support what you're doing. So
definitely.
I'm going to bring up.
I was going to say, it's nice to say that, yes, that's predicted life expectancy, and then there are tables online where you can put in your age and stuff like that to calculate or estimate the life expectancy. But anytime I see that, I think of someone trying to make us play God. Really, how can you tell someone, yeah, you have less than 10 years to live, and we're not going to do a biopsy, we're not going to do a PSA? Again, I think shared decision making, you present the options, you tell the patients, okay, life expectancy among Americans is this, you are at this age, doing a biopsy, repeating your PSA, screening you for prostate cancer may cause you more harm, financial toxicity, physical toxicity, psychological toxicity.
Yeah.
Do you want to proceed? And if I were to do a biopsy, and if I were to find cancer, low grade, favorable, intermediate, unfavorable, intermediate, do you want to have treatment, knowing here are the potential side effects of treatment? And if the answer is no, I'm not even going to start them. I'm going to say, oh, well, then why even bother repeating your PSA?
That's a good point.
If this is an 89-year-old guy.
That's a discussion that's really important. If the patient says, well, I got a PSA, I want a biopsy, but I'm not going to have any treatment, you're wasting it. Why get the test even? I have a question that came in from our Ask Euro nurse. I want to bring that one up because I think it falls right into what we're talking about. So what are your thoughts on PSA screening for active and healthy males over 80 years of age? That came in from Nadine. Thanks for that question, Nadine. What are your thoughts, John?
An active, healthy 85-year-old?
80-year-old plus, yeah.
And what is the question regarding that gentleman?
Should we screen that patient with PSA?
So again, right? You look at the life expectancy of a typical American. If you look at the table, the actuarial table, he doesn't have 10 years. But then you look at you have to individualize to the patient. I have patients who have a known history of longevity in the family, and he'll tell me my dad is 92 years old and he's still walking around living independently. And you look at the history of the patient. Is he morbidly obese with diabetes, hypertension, history of stroke and heart attack? Then you say, okay, you probably are going to fit into that criteria, fit into the actuarial table of having less than 10 years life expectancy.
Right.
On the other hand, if you have a healthy guy who is playing pickleball every week, every single day, every other day, then you start having the conversation of, okay, well, this may impact on your longevity.
I think the key is having the conversation, and that's not something that was done in the past. Early on, when PSA first came out, everybody just reacted to the number. So I think it's a great thing, especially if you find a urologist who sits down and takes the time, and especially in today's busy schedules, to actually talk to you. That's stick with that person. It's a great thing.
Yeah.
All right. So Heather Hansen has a question for us. What to do? Age 55, who has had no PSA or DRE. Patient is being tested or treated for kidney cancer with chemo and he had nephrectomy at age 48. His oncologist said he doesn't need a PSA. Wouldn't change treatment. Any thoughts? His father had prostate cancer. Wow. Nice challenge, Heather.
Well, yeah. Well, I guess it would depend on the. So it seems like he has aggressive renal cell or some sort of a kidney cancer, and he's already had an nephrectomy. He is well, no, he had. Oh no, this guy is now 55, so he is 5 years out, over 5 years out from his nephrectomy and chemotherapy. So he's
Right.
considered cured from his kidney cancer. So now you can kind of put that aside, right? So that is no longer, that is really no longer in play. Now, in essence, you have a 55-year-old with a family history of prostate cancer and never had a PSA or DRE. So that fits the criteria. If you talk to the patient, hey, I certainly would offer prostate cancer screening to this 55-year-old guy with a family history of prostate cancer.
Yeah. And I mean, and how many patients have you seen in your career that have had multiple primary tumors? They have kidney cancer, prostate cancer, testicle cancer. I mean, all sorts of primaries, and they're treated and cured of all. I think the biggest I saw was one patient who had 4 primary tumors and had cure from all 4. So as you say, you don't want to miss that.
Yeah, and people who survive pancreatic cancer after Whipple.
Exactly. Yeah. Nancy said, I have learned from my collaborating urologist that he always does a limited biopsy for tissue sample to confirm. So that
probably regarding that patient with the grossly abnormal rectal examination and grossly elevated PSA. Some guys will come in with PSA over 100 and they do the rectal examination. You know that this guy has metastatic prostate cancer. Yeah. I would recommend a limited biopsy for numerous reasons.
And Susie Swain kind of says, involve patient in decision-making process, which is what we've been talking about. Mm-hmm. Absolutely. Have you used that prostate cancer risk tool at all, John?
Yeah, and I also included that link in our chat.
Yeah.
In StreamYard. Yeah, that's a good tool in discussing risks of finding prostate cancer or low-grade prostate cancer or no cancer with the patient, and then come up with the decision. And like you said, Vic, if the chance is 3% and you're one of that 3%, it's 100% for you. And that's one line that I talk to the patients about. I do tell the patients that, the risk is low. For instance, less than 4% chance of having infection after a prostate biopsy. Well, if you're one of that 4%, it's 100% for you.
Yeah. And I think that's sometimes you have to remind patients. And, you mentioned earlier with some patients want the doctor to kind of say, there's just a paternalistic, hey, I'll take care of you. Here's what to do. And you also see educational backgrounds are varied to, some patients who are only high school educated to patients who have more degrees than we do. So it's kind of, you have to match the education level too with, what you're speaking to patients about. But I think those diagrams just really drive home the message, something visual that patients can look at. And I apologize because using the green screen, you couldn't see those little dots.
The green circles,
Green circles.
Should have been happy face green circles.
They're happy faces, and some of them got thermometers in their mouths to simulate what you are as if you're one of those 3%ers that ended up with sepsis. And they weren't smiling either.
Yeah.
So you couldn't really appreciate it. So if you haven't used it, I would strongly encourage you to take a look at that. I think, in our practice, everybody's got an iPad and a laptop when we go into the office. So it's easy enough to throw these numbers into the screen and show the patient and then kind of help them. As you say, our job is to guide patients in making good decisions for their health, but not necessarily putting them through things that they don't understand the risk for.
And I really appreciate the recent advances in screening, such as multiparametric MRI. So you have a guy with elevated PSA, and I do look at the PSA velocity, and it's always a small piece of what's going on. Typically, I look at serial PSAs, so the guy can come in with multiple PSAs. I see, it's slightly elevated. Ooh, PSA velocity has gone up. Ooh, percent-free PSA is abnormal. Then I'm going to counsel the patient. Yeah, we're going to probably go straight to a prostate MRI and instead of repeating another PSA, because I see this worrisome trend of rapid increase and abnormal PSA and abnormal percent-free PSA. So if they've already come in, if they come in with already having that package of information, then I go straight to a prostate MRI and then possibly a biopsy, depending on what the MRI shows. Again, after another sure decision making. And for those of you who are not doing telemedicine, these discussions are great for telemedicine.
Yeah. Yeah, because you can bring those things up on your screen if you have
share that. Yeah. And then you can securely send these reports to the patient.
Yeah, absolutely. I agree. Nancy said NCCN guidelines are very helpful for practitioner and patient. Agree. I think, it's always good to be able to fall on something with evidence behind it, not just dogma. Yeah. So much of our practice has been dogma in the past. I think it's just makes sense to look at the literature. I enjoyed getting ready for this talk, just looking through all the literature out there. Of course, I've got a vested interest in this, being somebody who's screened for prostate cancer, which fortunately so far so good. But my other thing is that I thought was interesting is, of course, I've been getting yearly PSAs, and really the evidence is now saying 2 to 4 years. If you've had, consistently low normal PSAs, shouldn't be going through this every year.
Mm-hmm. And I'll share something personal, just like you are. My PSA is less than 1, and I've been screened for prostate cancer now for several years. And it is always a little anxiety provoking, even though you're just getting a blood test. It is anxiety provoking because of what you know, right? Because of what you see every single day. So getting the PSA, especially for someone like me whose PSA is so low, getting it every 2 years, 3 years, 4 years is probably appropriate instead of repeatedly sticking the patient for it. Even though someone with my history and also at my age, I'm probably being stuck for venipuncture for something else every year anyway.
Yeah, it's not you had a good point. It's not the needle stick that hurts. It's the anxiety waiting for that number to come in. It's interesting. I've changed healthcare providers since I moved to Indiana. And so I go in, I get my blood test. I can't even drive from the lab to my house and get there faster than the blood test result is there. Literally, as I'm driving, I get a notification on my
your results are done.
Your result is, and I'm like, holy cow. So talk about instant. But before, you would get the blood test and then you have to wait several days maybe to get the results. If you weren't like you and I, privileged to be able to get your results right away, you had to wait till you saw your physician. It's a lot of anxiety.
Yeah, and I do have some patients who will look at the result, that singular result from your order of the PSA or the blood draw, and they make a decision themselves. And they often say, well, I don't need to talk to you. I already know what that means. Well, you can't really look at a singular lab in isolation in a vacuum. You kind of look at the entirety of the patient, the history of the testing, family history and stuff like that, and then come up with a decision. And you have to keep in mind as a nurse practitioner, PA, you have to keep in mind they're paying you for your expertise and experience. So it's not just looking at a lab, it's interpreting the lab. And also you are assuming liability for that interpretation. So that's why you're getting paid. Is for your experience and everything else that comes with what to do with that lab value.
And even if you are a healthcare practitioner and you're involved and you get your own number, like I do, I see my number, you always need to go and still have that, looked at by somebody else. Make sure you're seeing a urologist, somebody, who can interpret it for you, because the most interesting thing I ever heard was somebody who treats themselves as a patient has a fool for a patient.
Yep, same thing. Lawyers say the same thing.
Yeah, don't treat yourself, even though you think, okay, I know the number and it looks good to me. Make sure you have it checked out. This is your life. Heather asks, what are your thoughts on select MDX and exosome testing? And we've had a couple of talks from those companies, so I think I'd look back at those. But again, the biomarkers should be. I agree with the PSA repeat, and that's still elevated, then looking at those.
I do find value in using the same family of products, Select MDX, Confirm MDX. I use Confirm MDX for the guys who has undergone a prostate biopsy and I find no cancer, and look at the methylation, make sure that I can safely check him a year from now, instead of having to follow him closely. Back in the day, anyone who had a benign biopsy after an elevated PSA had a repeat PSA and possibly a repeat biopsy in the next 3 to 4 months. And that's, again, financial, physical, and psychological toxicity associated with it. So now we have better tests to determine whether or not the patient requires such a rapid follow-up or biopsy. And Confirm MDX is one of those tests. And it's in the same family as the same company, it's from the same company as Select MDX. So I do find value in the appropriate patients for these types of ancillary testing for elevated PSA and history of benign biopsy. Yeah,
no, that's a good point. I think that it's a great time to, I guess it's a great time to have prostate cancer if you ever had to have it, because back in the day, like I said, I've been involved in urology for 40 years. When we saw prostate cancer, this was pre-PSA, these patients often came in a wheelchair.
Yeah, it's really sad.
It was a much sadder situation. And I think that's probably why people are more anxious to try to diagnose and treat early for that reason. But again, then, that the pendulum swings the other way and we've overdone it. So it's good to have options now.
And to the nurse practitioners and the PAs who primarily are doing the examinations and seeing the patients, and you're not, whether or not you're seeing the patient incident to, we're talking about billing now. If you are seeing the patient primarily and you are not sure about what you're feeling with that rectal examination, be sure to rope in your supervising physician and have him or her repeat that digital rectal examination. I recently saw a gentleman who is African-American with a very high PSA, let's just say above 40 in urinary retention. And the nurse practitioner or the PA who saw the patient initially did a rectal examination and said everything felt fine, and didn't mention anything about the elevated PSA, and simply said, we're going to schedule you for a cystoscopy in about 4 to 6 weeks, because that's when that's when they could get the patients in for a cystoscopy. He came in for a second opinion. I looked at him and I said, well, we're going to deal with this grossly abnormal rectal examination and this very high PSA first by doing a prostate biopsy. Don't pass go, don't collect 200. We're going to do a biopsy first. That we're going to keep the catheter in and then deal with that later. So if you're ever in doubt with that rectal examination, make sure you get someone to get a second opinion in your practice.
Yep. And we'll take one final question. Dr. Lin, we do trust biopsy. What about perineal? Any thoughts?
Yeah, recently there's a trend towards perineal biopsies because the problem with transrectal biopsies is a slightly increased risk of infection, sepsis. Right. And perineal biopsies decrease that risk, but it does require some special instrumentation. And of course, it's something new. And also, it's more work in setting up, but you have the reality of medical practice, and then you have the billing and coding aspect of medical practice. You're not compensated for all the extra work, energy, materials for a perineal biopsy. So those are the dilemmas, but it does decrease the risk of infection in certain cases.
Yeah, and I don't think it's far from becoming the standard of care. Trust biopsy still is the gold standard for obtaining samples. All right, well, we're going to bring in a...
Wait, hang on. One more question. Do you want to answer that?
I think I'll send that guy answer offline. It was a patient question.
Got it.
I don't think it's appropriate to do here. All right, so here's next week's little clip.
Sonoblate high-intensity focused ultrasound has emerged as a pioneering treatment option for prostate cancer. It offers patients a minimally invasive alternative to traditional surgery or radiation therapy. Dr. Arpit Shah will discuss this innovative technology utilizing focused ultrasound waves to precisely target and ablate cancerous tissue within the prostate gland, while sparing surrounding healthy tissue from damage. By delivering high-intensity energy to the affected area, Sonoblate effectively destroys cancer cells, leading to tumor shrinkage and disease control, all without the need for surgical incisions. Join us next week on UroNurse to learn more.
So I'm looking forward to hearing more about that next week. Hope everybody else joins us next week to learn more about this new prostate treatment. And we'll see everybody next week. Hey, happy Easter, everyone. See you next week.
Bye.